So sputum volume, sputum change in color consistency, volume change in color and consistency, and increase in sexual suction. So you have to have one of these. So in this inflammation you need to have one. Okay. In the clinical features you should have either this, or you should have the PF ratio to change, or requirement of oxygenation to be increased by more than 20%, or requirement of PEEP to more than 2. So you should have one of these features. You can't call it ventilator-associated pneumonia if you don't have any of these features. Samajh mein hai? Are you understanding this? So what are the few things that you need to look at? You need to look at so that's why I am dividing it easily for you to make it to at least one of this, at least one of this. So at least one of this, at least one of inflammation. So at least one of inflammation, you will have what all? Fever, WBC count going up, and the cough. Either WBC count going above 12,000 or a WBC count going less than 4,000. Okay, either this or that, plus a cough or a fever. That comes in the inflammatory part. That at least one of that has to be there. And in the at least one of the rest, where you're looking at clinical features for VAB, we're looking at increased secretion volume, purulence, or consistency, or increased requirement for suctioning. So 4 things are there in that. One of these have to be there. Either one of this, or you need one of PF ratio changing, or the PEEP. You are changing the FiO2 by 20%, or you're changing the PEEP. You have done one of these maneuvers. Clear? So you should have. So what I'm now understanding, you should have a radiological appearance. You should have one of inflammation and one of the clinical features, and you should also have a microbiological diagnosis.
So in this clinical examination, basic pneumonia factors like colonoscopy.
So RAS. So it comes in this. It comes right here. It comes in clinical features where you say RAS, sputum, and then there's RAS also. New rails. New RAS comes over here. Sorry, I missed it out, but this comes here in the clinical features rails. Okay, new RAS. Okay. So out of these 3, you need one. But generally, what usually you see is sputum. That is what you generally see. Gram stain culture, or sputum volume, purulence, consistency, or increased requirement of suctioning. This is what you normally get from your from the clinical features. Okay, so what PF ratios? You should know this, because why is this definition made? Why is this definition made? Why is this definition made? This definition is made because you need to do surveillance. So when a person is doing surveillance, what is surveillance? Surveillance is trying to pick up. So if there is an infection control nurse that is coming every day to the unit, she will look, radiology में change हो गया क्या? इसमें I have to follow this patient's gram stain. The next step further will be, ये तो आ गया है, I have to now follow this to call it as definitive lab. Are you understanding? For surveillance, this is the definition that is used by the CDC. You understand? This is the definition used by the CDC. Clear on this? Clear? So you have now come to clinical. Now you have come to microbiological. Okay. In the microbiological feature, or laboratory you could call it, what would be the features? First feature would be if there is a positive blood culture. You don't just a positive blood culture. Because blood culture is sterile. You didn't have any infection in the past. You didn't have anything in the past. Now you have got a blood culture that is positive, and you have a radiological sign, and you have a clinical feature. This goes in favor of VAB, definitive. This becomes definitive VAB. You understand? Clear? Clear on this till now? Blood culture. Second thing is pleural fluid culture. So have the right words in the first place. Definitive. Because pleural fluid जो रहता है, pleural fluid is supposed to be sterile. You can't have anything unsterile in the pleural fluid. The moment you get pleural fluid that is positive with an organism, you are dealing with probable or definitive ventilator associated pneumonia. That is why what we say, if you have a patient on the ventilator and you have a pleural fluid, you can see, tap it for diagnosis. Tap it for diagnosis. Are you understanding? That's why you tap it to figure out what is it. Okay, if it is positive for a culture, we will call it as ventilator associated pneumonia if there is the presence of a new progressive patch or there is the presence of clinical feature inflammation. Clear? Clear on this? So you will be a second. Then the third is what she mentioned. That is a sample. A sample that comes from inside. And when we say sample that comes, it can't be a sputum. Whoever said sputum, it's wrong. Completely wrong. Why is it not sputum? Because sputum is an upper respiratory tract. When you're saying lower respiratory tract, it can be only one of the three. Which are the three? It can be either bronchoalveolar lavage, okay, or it has to be protected specimen brush, or it has to be endotracheal aspirate. It cannot be any different from this. Okay, it has to be either endotracheal aspirate. It has to be protected specimen brush. What is protected specimen brush? It is basically a brush where there's an external cover. There's a brush inside. The entire thing will go in bronchoscopy inside to the existing area where you have the patch or wherever there is, and then this will be taken out. This will go inside. It will take a sample of it by brushing, come inside back and take it out. Okay, this is protected specimen brushing. Okay, so PSB, bronchoalveolar lavage, and it is secretions. And what do they show? They should either show a gram stain that is positive, or a microorganism that is growing, or they should have BAL that is showing intracellular pathogens. They should show more than 10% intracellular pathogens. Clear on this? Either you should show a gram stain that is showing something, okay, or you should have an organism that is growing, a regular organism that is growing. You can't have any irregular organism. You cannot have any. It has to be some organism that you normally see, not a diphtheroid or something like that. Okay, and apart from that, or you should have more than 10% of the cells having intracellular pathogens. Okay, this is what will tell you that this patient has got VAP. And the last criteria in this case is what? A histopath diagnosis. Histopath. So if I go inside and I culture, I take a biopsy, and that biopsy is supposed to be sterile, your lung is supposed to be sterile, and you do a biopsy and you get an organism. You get an organism, then it will be called as ventilator associated pneumonia. Am I clear now? So this completes your diagnosis. So if you want to complete it, because what did we start by saying? You may either overdiagnose and overtreat, or you may underdiagnose and undertreat. You cannot be in both the spectrums. You have to be definitive in your work. And to be definitive, we need to have these criteria in place. So whenever you are actually having a ventilated patient and you find a small FiO2 change also, don't disregard it. Write it down. There has been a change in the FiO2. Okay, and how can you remember all these things? By writing it on your paper. When you are having a patient on the ventilator, any clinical feature, any radiological changes, any microbiology, any secretions, likhna zaruri hai, so that you will remember all your life that this is what I need to have to call it back. Unfortunately, what happens? People are not trained. Unqualified people are working in many places. Okay, and what happens is you do a chest X-ray, you find, अरे यहाँ पर तो patch आ गया, चलो antibiotic पड़ा दो. What is that? That may not be a patch. That might be just an atelectatic shadow. That may be just a nodule that is over there. Maybe just an effusion related underlying collapse. You understand? And then next day patient becomes normal. देख मेरे antibiotic काम किया. Antibiotic थोड़ी काम किया. It's just your ventilator that has worked. Are you understanding? Another problem. You have a patient on the ventilator. He develops a fever. इसको VAP हो गया. चलो चालू कर दो antibiotic. Extremely wrong things to do in when you look at intensive care medicine. It's extremely wrong. And why is it wrong? Because you are going to cause collateral damage. Patient will not improve. Patient will worsen. At the same time, you're causing damage to the environment. It's not something that you need to do. It's completely wrong. Clear? Arshad, you understood?
Yes, sir.
Okay. Now, so this is the diagnosis. This is the complete diagnosis. Okay. Now the question comes: if I put all of these together into one bucket, it's called as hospital-acquired pneumonia, isn't it? The whole thing is called as hospital-acquired pneumonia. And now, how do you treat them? So she did mention something. I will make it more clear. Okay. You understood the ventilator-associated bundle. Bundle. What is the bundle? What all it says? So what is bundling? What is the meaning of bundling? What is the meaning of bundle?
Few steps which are to be followed, or we should be prevention.
So what they did was they found that there were various measures that actually improved problems. For example, in sepsis, there were various things that you did when it improved sepsis. In central line associated bloodstream infection, there were many things that you could do which will actually improve the prevention of CLABSI. There in urinary tract there was something that will prevent cord T. Similarly in VAP, there were many things if you do, all the things if you do all the time, then only patient will do well. You can't do one and leave the rest, or you cannot do three and leave the fourth. Are you understanding? So when you say bundle, it means you bundling them together. It will not work if you do one thing, or you do four things and you miss out one. You have to do all of them on a regular basis. So doing all the aspects of the bundle all the time is the meaning of following a VAP bundle. You understand? That's the meaning of bundling. Clear on this? So what is the bundle? What is the bundle and what would be the problems that you have with this bundle? Let us see. Okay. What is the first part of the bundle?
Avoid intubation.
So first thing is avoiding intubation. Now avoiding an intubation doesn't mean that you delay intubation. Avoiding an intubation means you don't delay. So the problem is when you try to avoid an intubation, there is a very high possibility you may delay an intubation. Intubating a patient in a delayed state is even more dangerous than avoiding the intubation. That patient will have a higher chance of mortality. Are you understanding? Clear on this? If I have a patient who requires an intubation, he requires an intubation. You can't just put an NIV and hope for him to get treated. That is not possible. Are you understanding? That is not possible. That doesn't mean a patient has slight RR and you intubate that patient. It doesn't mean that. That is where the clinical work comes in place. You don't keep waiting. He's put him on NIV. He's going on and going on and going on for 4 hours and 5 hours and 6 hours. And then you're intubating means that patient will arrest only in some days. He will not going to make it. Are you understanding? So that is why you have to be very certain when to stop your NIV, when to stop your HFNC. You can't just keep on doing stuff like that by just monitoring the pain. This is what occurs in most of the ICUs. What happens? They put the patient on an NIV and they think that the patient is going to improve by magic. It doesn't happen. NIV is just support. What is going to improve if it's pneumonia? Your antibiotics. How much time it takes? It takes a long time. It's not possible to change immediately. Are you understanding? So avoiding an intubation is important. However, delaying an intubation is very harmful. So in the event that you have intubated a patient after a trial of long NIV, means you have harmed your patient. Are you understanding? That means you have harmed your patient. You have definitely harmed your patient. That is the reason that you need to ensure that you intubate early at the right time. Right? And that is where you are learning in critical care. In critical care, every day this is what you are learning. Oh, this patient is getting worse. Oh, this patient is bad, so arrest ho jayega. Udhar then you have missed the bus. If you have come to a condition where you are calling me and saying that, अरे sir, वो तो बहुत breathless हो गया सर, अभी arrest हो जाएगा सर, मैं intubate कर देता हूँ. मतलब वो तो बहुत ज़्यादा आगे बढ़ गया है. मतलब you have missed it out. उसको पहले ही intubate करने का था. Are you understanding? And this is exactly what I hear from you all many times, which is completely wrong. Are you understanding what I'm saying? So your presence in the ICU is for taking these decisions. Okay, you have to understand अरे ये तो ventilator associated pneumonia है या ये pneumonia है, pneumonia को ठीक करने के तो time लगने वाला है मुझे, मैं उसको बार-बार ऐसे जोड़ों से श्वास लेके what am I causing? I'm causing injury to his lung. He is breathing so fast at 35 and 36 or 30 or whatever, you are causing injury to the lung. जो pneumonia हो रहा है वो biotrauma हो रहा है अभी उसको. Are you understanding? So I need to take this call and quickly intubate these patients. You understand? Clear on this? Am I clear? So the intubation part cannot be delayed. If you say that one bundle when you're talking about that, you cannot delay the intubation. So the word is wrong when you said it should delay. It is not delay. Okay? If you delay intubation means patient's mortality will go up. Clear? That is why that is the clinical call that you're going to take. Then the second, what is the second?
Avoid daily sedation medication.
उससे पहले head and elevation. Most important, head and elevation. Okay. Now, what can be the problems, practical problem with the head and elevation? Sachin, what do you think would be a practical problem with head and elevation?
Sir, in that position, first of all, comfortable always like.
What is the problem with this position? So first of all, when you say head and elevation, what are you looking at? What degree? 30 to 45 degrees. This is what the guideline says. What does the VAP bundle say? 30 to 40 degrees. 30 to 40 degrees of a head and elevation. How do you know 30 to 40 degrees, Arshad?
So, side में monitor है sir.
Side में?
Monitor attached है.
Gonioscope होता है. That's called gonioscope. There's a gonioscope on the side. Have you seen it on the side of the bed? There's a small meter that actually tells you where there's a small dot or ball that is there. Have you seen it?
Yes.
Have you seen it? You've seen it? The side of the bed?
Yes.
You've seen it?
Yes, sir.
So that has to be 30 to 45 degrees. Okay, first is avoid. Second thing is head and elevation. The problem that you have is in this position, this patient is lying like this, right? This is how the patient is lying. Now what is happening? The entire weight of the body is actually on the sacrum. The entire weight of the body is on the sacrum. Very very difficult for the patient because he will start getting pain. Okay, within 2 hours you will start getting pain. Okay, that is the first problem that you can get. Second thing, these patients are ill. Their body is fighting to keep the BP up mostly in these cases. So all the peripheral circulations have been moved towards the vital organs, towards the kidney, towards the lung, towards the heart. So there is less perfusion over here. And then you're making the patient sit like this on a propped up position. So what can develop? A bed sore. Okay, you can develop a bed sore quickly. Within 2 hours they develop a bed sore. Within 2 hours. In 2 hours if you don't change the patient will go to bed sore. So you can't say propped up position. It is wrong. You understand? You keep the patient propped up, it is wrong. If you are doing this, stop doing it. Okay? You can't tell the patient to be at propped up position for 24 hours and 6 hours and 5 hours. You cannot do that. It is not possible. Okay? It will cause problems. Okay? It will cause bed sore. First thing. Second thing, what is the second practical problem? Have you seen a patient sitting like this? Have you seen a person like this? When you see a person like this, what do you see? अर्षद क्या दिखता है? अगर पेशेंट को आपने ऐसा पोजीशन में रखा तुमको क्या दिखता है? पेशेंट पे क्या दिखता है तुमको? What do you see? What do you notice? Anybody? What do you notice? What happens to the patient? What happens to the patient? The patient can never maintain that position because he will slip down. He will slip down. Patient slips down. Very difficult to maintain that position. That is why they try to put a bed break under the popliteal area and all these things so that patient doesn't slip down. But invariably, what happens? Patient slips down. So when they did studies to see whether we can maintain the patient at 30 to 45 degrees, they found only 10% of patients that could be maintained at that position. Only 10% patients that could maintain. But why are we thinking of this position in the first place? To avoid aspiration. This was the thinking. Avoid aspiration. But what we know, it doesn't really avoid aspiration as much. It doesn't cause so much of aspiration deficiency. Improvement. It doesn't do that. Okay. That is why now we don't go at 30 to 45 degrees. We are okay keeping them even 10 degrees to 20 degrees. They are okay to keep them even 10 degrees to 20 degrees. Clear on this? Head and elevation? Huh?
It's according to the guidelines. It's okay now.
Yes, 10 to 20 degrees, above 10 degrees. Okay, huh? Clear on this? Alright. Huh? What is the third one? Subglottic suction drainage. Very important. So this is something that has come in. Subglottic suction drainage, which has actually changed mortality, which has actually changed the incidence of ventilator-associated pneumonia. Okay, not mortality, ventilator-associated pneumonia. Subglottic suction drainage to be done every 2 hours is very very important. That is why what do we do when a patient comes from the OT with a normal tube? We change it to a subglottic secretion valve tube. We change it because we are expecting this patient to stay for a longer period of time. We do that. Okay, we change it to a subglottic secretion valve drainage. Clear? Because OT patients will not have that tube. They'll come to the ICU, we change it to that. If we expect the patient is going to be for 2 days, 3 days, say a bypass patient has been difficult to manage. It's come from the OT. Okay, 2-3 days, we are expecting this patient may require IBP, 2-3 days is going to take place. What I do? I put a patient on subglottic suction drainage because it is very important to prevent ventilator associated pneumonia in such cases. Clear? Subglottic suction drainage. Clear? Subglottic suction drainage. Very, very, very important. Okay. Then chlorhexidine mouthwash. Okay, now oral hygiene, we call it as oral, we don't call it mouthwash, we call it oral hygiene using chlorhexidine 0.12 to 2%. You have to say this. Oral hygiene with chlorhexidine, of which there is huge controversy whether it has to be done every 4 hours or every 8 hours. There is huge controversy on that as to how much time you have to do it, whether you have to do it 2 hourly, whether you have to do it 4 hourly, whether you have to do it 8 hourly. There is a controversy on that. But what is this? What is important in this? This oral hygiene with chlorhexidine showed maximum prevention of VAP when in which patients? In CVTS patients. This maneuver, oral hygiene, did maximum benefit when you did it for CVTS patients. This is important for you to understand. Okay, yeah. So if you have a CVTS patient, it is imperative to have chlorhexidine mouthwashes. Not that it is not for others, but it is imperative. Okay, that you do chlorhexidine oral hygiene for these patients. Chlorhexidine oral hygiene. What is the problem with chlorhexidine oral hygiene? There is a possibility that you may aspirate and cause aseptic pneumonitis in the lung. You know, it may cause pneumonitis, which may cause inflammation. So we are worried about aseptic pneumonitis in the lung. So chlorhexidine has to be used very carefully. Inflation, then you suction, then you clean, and you oralize. That's why when you see in the morning, you should always see the mouth. When a patient on ventilator in the morning, always see the mouth. I do that every day. Any patient, I follow the same thing for all patients. Okay, I just follow the same thing because it's what you're supposed to do. Alright, clear on this? Chlorhexidine. Then, yeah, so a daily sedation awakening trial and a SBT. How does this prevent VAP? How do you think this prevents VAP?
Minimum the day of intubation.
Yeah, so it is known that if it is permissible to do a spontaneous breathing trial, you can't do a spontaneous trial, the patient has a PEEP of 10 and 15 mm. Only possible. If I do 100% SBT, नहीं करेंगे. You understand? If it is permissible to do an SBT, okay, if you permit to do an SBT, that the PEEP is not very high, the oxygenation is okay, we are not struggling, the patient is not in prone ventilation, all this nonsense that's happening, the patient is not in that severe ARDS situation. In that patient, it is very important to have a daily spontaneous breathing trial or a sedation awakening trial because it reduces the duration on which this patient is mechanically ventilated. If you reduce the duration of mechanical ventilation, you will reduce the incidence of ventilator associated pneumonia. Clear? Clear on this? Savna? Any doubts? Okay. Okay, then in the bundle there is two more things which I don't know why it is there. Okay, there is one bundle in which there is DVT prophylaxis and there is PPI. So you should not mention this. I don't know why it is there. It is there in the bundle, but there is no reason to say why it is there. DVT prophylaxis is not going to prevent VAP. Similarly, PPI is in fact going to increase VAP. You know, it's going to increase VAP. That's how it is. Okay, clear? Clear this? So, but if the MC, you have to give the answer as per the MCQ. Okay, the MCQs generally will not have these things because we know that this doesn't work. You know, this bundle was given to us by NHSN. That is the CDC guideline in the United States where they included these two things. Okay, your MCQ will not have this. No doctor will come and keep asking you what is next, what is next, what is next. No critical care doctor in exams will ask you this again and again, but it is there in the bundle. If an exam is going on, they will ask you, tell us a partial. But in this, when you are actually asking a question on bundles, you don't go and say, I will keep disposable tubes, I will put HME filter, I will do closed suction drainage. वो सब नहीं बोलना है. You understand? That is not what you're supposed to say. I will do daily bronchoscopy. This is not. The bundle is this. The bundle is this. Of all you have to do, we are not counting this one. We are doing all of this all the time. Unfortunately, what happens is when you ask, okay, tell me the VAP bundle, sir, closed suction drainage. It starts that way. You understand? It starts that way, which is not what we want to hear. Sir, I will change HME filter every day. This is what comes in. But that is not the bundle. They are adjuvants that you may want to do in order to prevent VAP, which has very low evidence. Closed suction drainage. Change the tube only when it is contaminated. Remove condensate from the tubing. Use HME filters every 72 hours. Okay, these are all things that are actually not completely proven in the bundle. That is why in the bundle we have only these things. Clear? Clear on this? Clear on this? Clear? Sachin, मेरे को एक कॉपी बनाने के लिए.
So by the time we diagnose a VAP, it will take us day 3, day 4 because by the time the cultures will come.
Absolutely.
But we'll empirically start.
Exactly. So now comes the question of how to start empirically. Okay, so now that you have asked this question, that question will now be answered now in our next how we are going to do this. She did explain, but I'll explain to you better. Okay, that how do I now treat it? She's right. So I will, by the time I diagnose VAP, it is going to take time, no? Microbiology. So you must understand my irritation when you have not sent a culture. You must understand my irritation when you have not sent a culture because it is going to delay.
That means by day 3 we have to send blood culture and
No. If you find a suspicion, send a culture. Do a ball, do a mini ball. You have a, that is why the surveillance pattern is there. No, you got a fever coming in, you did a chest X-ray or you did an ultrasound. You thought there is a new thing that is coming in over there. So I have a radiological feature, I have a clinical feature, and now I am seeing some secretions increasing. I am thinking that this may be a VAP. Okay, I need the culture quickly because I need to demonstrate the presence of gram stain that is having organisms or a culture pattern that is positive, isn't it? Isn't it? So then what happens is, say one day prior this patient has been intubated and next day morning I come and say, "Arey iska culture bhejo." I have missed out how many days? One whole day I missed in the diagnosis of VAP. Are you understanding? Are you clear? Clear on this? That is why you should know the definition of VAP. That is why the person staying over here, working over here should know the definition of VAP. एक फीवर आ गया, चलो पैरासिटामोल दे दिया. अरे फीवर आया, वेंटिलेटेड पेशेंट, उसको देखो भाई ये वैप है कि नहीं है. Are you understanding? Fever आया, is this VAP? I'll start thinking because I got an inflammatory feature there. Are you understanding? समझ में आ रहा है? हाँ? That is why you should be very, very careful. So all the things that you did was wrong. You intubated late. You didn't send the ET secretions for culture. Everything that you did was wrong. I'm just trying to tell how you can get better. Okay. So you should be able to. You cannot just put a patient on a BiPAP and keep him for a long time. It's wrong. You should have intubated long ago. Okay. समझ में आ रहा है? Clear on this? So now the question that comes to us is, what do we do as empirical treatment? Our biggest problem is empirical management. एक बार आ गया कि ये बैक्टीरिया है, it is simple. You know what is to be done. It is not difficult. It is not rocket science. But the entire clinical know-how is how to treat this empirically. Okay. Now how do you treat this empirically? So you have, say, a feature of HAP or VAP. I will differentiate them into severity positions. Because my question is, do I give 2 anti-pseudomonal cover plus MRSA? What I have to answer when I'm actually treating these patients? When I'm treating these patients of hospital-acquired pneumonia or ventilator-associated pneumonia, मेरा मन में एंटीबायोटिक के बेसिस में आई एम वेरी क्लियर, आई एम नॉट गोइंग टू यूज सेप्ट्राइजोन ऑल दीस थिंग्स. मेरे मन में क्या है? Am I going to use 2 anti-pseudomonal because it is VAP or HAP? No, it is hospital-acquired. You are going to have bacteria that are difficult to manage, right? You can't treat them with community-acquired pneumonia kind of antibiotics. Am I clear on this? When you have HAP or VAP, I can't treat them with community-acquired pneumonia kind of drugs. Which are the community-acquired drugs? Ceftriaxone, azithromycin, augmentin, levofloxacin. These are all community-acquired. This is for community-acquired pneumonia. You understand? If it's general, simple community-acquired pneumonia, we start all these things. But what am I dealing here? HAP and VAP. Both of them have a high tendency to harbor difficult to treat organisms, of which organism I am scared of? Pseudomonas. I am worried very much about Pseudomonas, because what happens to Pseudomonas? The drugs that work with Pseudomonas, and there are drugs that don't work with Pseudomonas. Pseudomonas is one of those organisms. Okay, where you will say that piperacillin tazobactam may or may not work, but cefepime will work. Are you understanding? Or meropenem will work. So I have to think whether I need to give 2 anti-pseudomonal covers or 1 anti-pseudomonal cover plus or minus MRSA cover. This is the question I have to answer. When I am giving an empirical antibiotic, I have to answer this question in VAP. Because VAP में Pseudomonas अगर आ गया तो difficulty हो जाता है. Acinetobacter आ गया तो difficulty हो जाएगा. So that is why I have to answer this question whether I want to use 2 anti-pseudomonal covers, 1 anti-pseudomonal covers, or this addition is MRSA. How do I do this? So how I do this is, once my patient develops a HAP or a VAP, whatever it may be. Okay, if it is HAP, I will look at 3 features. What are the 3 features you mentioned then? IV antibiotics in the last 90 days. That is the first feature I will look at. The second?
Septic shock.
Septic shock. You will look at septic shock. And third?
Renal replacement.
Requirement for ventilation. Okay, requirement for ventilation. That means patient was admitted to the hospital, patient was in the wards, patient has come down with breathlessness, you have noticed a new patch that has come in with fever and the presence of this clinical feature, and now you are suspecting this patient has got hospital. Thank you very much. You are suspecting patient has got hospital acquired pneumonia. This is your suspicion, right? You understood the case? Now my thinking is मैं इसको क्या चालू करूँ? वो वार्ड में सेप्ट्राइड जोन पे था. मैं what do I start this patient on? This is my thinking. So then I will look, is this patient in septic shock? Okay, in the last 90 days, has he received a course of antibiotics? Okay, or is this patient in florid ARDS where I have to intubate? Acute onset with that definition, PF ratios of less than 300, all that which we diagnose for ARDS, does he fit into those pictures? Okay, that means he requires ventilation basically. So if he requires ventilation, this hospital-acquired pneumonia is severe. If he is in septic shock, this hospital-acquired pneumonia is severe. If he has IV antibiotics, the chances of having MDR organism with the severity is higher. Clear? Clear on this? On the other spectrum, when the patient, say for example, was on a ventilator, patient like for example, you have that patient on bed number 4, she is on a ventilator. She's on a ventilator. She was on a ventilator. Now, 3 days later, this patient develops a fever. Develops a fever and you do an ultrasound, you find a new patch. Now your thinking is, अरे यार ये तो शायद गैप हो सकता है, मेरे को empirically या तो फिर इसको डबल, सिंगल, नहीं तो प्लस और माइनस MRI से चालू करना है, बराबर है? This is my thinking again, same thinking. So what will I do? Again I will put my severity factors over here. Which are my severity factors? These same things will come here. These same things will come here. Ventilation, when you will say ARDS ventilation. When you come down, what is the next thing you will say? He had ARDS prior to VAP. ARDS prior to VAP. मतलब पेशेंट को तुमने इंट्यूबेट किया था कुछ और के लिए, मतलब ARDS के लिए इंट्यूबेट किया था, अभी ARDS वर्सन हुआ है. ARDS के तो बहुत सारे मैनिफेस्टेशंस होते हैं, पैंक्रेटाइटिस हो गया, ये हो गया, वो हो गया, कुछ भी हो गया. समझ में आ रहा है? लेकिन वो ARDS के लिए तुमने वेंटिलेट किया हुआ है उसको. समझ में आ रहा है? और पेशेंट हैज रिसीव्ड रीनल रिप्लेसमेंट थेरेपी in the last 5 days. Clear? Am I clear till now? Interesting, no? Now it becomes very simple. The moment you get a pneumonia, you just tick mark these boxes. Right? 90 days में मिला antibiotic. Has the patient is the patient in shock? Is the patient having ventilation requirement? Any of these is there? Any of these? इसमें से एक या इसमें से एक. That means to say, I need a double anti-pseudomonal cover. Clear on this? So, renal replacement therapy. कोई भी, समझ ले, for example, patient को intubate किया तुमने, patient को intubate, like think example that guy, patient को तुमने intubate किया है, he had hospital-acquired pneumonia. Okay, now you have intubated him. Now 2 days later, you find the patch to be increasing, but he already had a RRT in the last 5 days. So his chances of having an extremely difficult to treat organism becomes high.
So means RRT का source that will cause extremely difficult organism.
RRT से क्यों होता है? RRT is known to cause all these factors. How they have come to these factors? After doing multiple population studies. After doing multiple population studies, मतलब बहुत सारे studies किए उन्होंने, 50,000, 60,000 patients के epidemiology देखे कि भाई ये कौन से organism को difficult to treat organisms आ रहे हैं. उस basis पे उन्होंने they came to this because initially what it was, initially very simple. Less than 4 days, more than 4 days. Less than 4 days give normal antibiotics, more than 4 days give higher antibiotics. This was what it was, which is not the criteria nowadays. Are you understanding? Initially when we started working, we used to do like this. So it's early VAP and late VAP. It's early VAP, let's give normal antibiotics. If it's late VAP, let's give higher antibiotics. This was what the thinking was. But what we realized over a period of time, it is not time dependent. It is dependent on the epidemiology. It is dependent on these factors. It is no longer time dependent. Are you understanding? So initially बहुत simple था. Initially patient comes within 4 days and after 4 days was the only denominator. It was very simple for us. Less than 4 days, ampicillin sulbactam plus teicoplanin add कर दो. More than 4 days, meropenem linezolid add कर दो. This was what we used to do. This is what we used to do. For a long period of time we did that. And then we realized, अरे ये तो early VAP में भी MDR आ रहा है. Early VAP में भी हमको MDR आ रहा है. Early VAP is also giving multi-drug resistant organisms. So there is something more. It is not time. It is not time. There is something more. And what is that something more? When they evaluated, they found these features. समझ में आ रहा है? And that is why now we are following these features. 2016 onwards, IDSA 2016 onwards, we are actually following these features. It's not very old. Okay, clear on this? समझ में आया? So they found that the RRT does cause a lot of problems. Why does it cause problems? If you ask me, Dr. Shrikant is coming to take a talk. But what normally occurs with an RRT is that these patients are essentially having vasoconstricted state, and RRT itself can cause an inflammatory cascade. An inflammatory cascade can cause an increased incidence of translocation of bacteria. There's a theory behind that. Okay, so that's why RRT patients have got RRT मतलब hemodialysis or renally present therapy have got a higher chance of going into these problems because they're essentially inflamed. Clear? Huh? It's a theory. Clear on this? So now we have come to this conclusion that if I have any of these that are yes, what am I going to do? I am going to put this patient on 2 anti-pseudomonal cover. So this could be a combination of say meropenem if it is anti-pseudomonal cover plus aminoglycoside, or meropenem plus some other antibiotic that covers pseudomonas like cefepime tazobactam with something aminoglycoside or something like that, which covers anti-pseudomonal covers. Clear on this? Or if levofloxacin is sensitive, levofloxacin. I'll be thinking in my ICU what is anti-pseudomonal, accordingly I will start it. Clear on that? 2 anti-pseudomonal cover. Clear? Now the question that comes to us is, do we add MRSA? This is the question. How do we answer this question? We answer this question. We have added this. No? The question is, do we add MRSA cover? Do we add ticoplanin? Do we add linezolid? Do we add vancomycin? Do we add levonorepinephrine? We have to think like that. Which is the gram positive cover I need to add? Do I need to add it in the first place? How do I decide that?
Hospital calculations.
No. You should know what is the prevalence of MRSA in your hospital. Simple. Okay. If the prevalence of MRSA in your hospital is more than 10%, okay, if the prevalence is more than 10%, then for a hospital-acquired pneumonia, for a ventilator pneumonia, you have to start. Huh? If you have more than 10%, for a ventilator pneumonia, you have to start. If you have a prevalence of more than 20%, I will start it for hospital-acquired pneumonia. For VAP, it is how much? 10%. But if it is HAP, I need more than 20%. Or I don't know only what it is. Or I don't know. IDK.
So for our hospital now,
Is more than 20%. That's where we start. You understand? That's where we start. Clear? Huh? Am I clear till now? Clear on this? Now what happens if the answer to this is no? What happens if the answer to this is no? This is yes का तो ठीक हो गया. Yes तो तुमको समझा? If the answer to any of this is positive or any of this is positive, yes, I am going to follow this pathway. Clear on this? That if I have any of the features that makes it, the severity high, okay, with respect to, so I have not even put timing, say 4 और 4 दिन 4 दिन आएंगी इसमें. There is no 4 days and less than 4 days and more than 4 days. I'll just put severity. I'll just put what I'm expecting as MDRs. They're going to be MDRs. So if I have IV antibiotic, septic shock, or patient having ventilator, or an RRT before that, or septic shock on the other side, or whatever I'm looking at there, then I'm going towards this pathway. But if I don't have any of these, which is possible, you have a patient who comes in from the wards, he was breathing heavily. Okay, you have come here, you have put him on a HFNC, and patient is reasonably settling. But I have got the feature that this patient has got pneumonia, which is new, progressive and persistent, with a fever that has come in, and he's producing cough, and I'm going to send this Putnam for culture. Isn't it? He's in that feature of hospital-acquired pneumonia or VAP. He's in that feature, but he's not this. He's not in shock. All of these things. That comes no, right? Okay, so you will have these cases. 50%, many cases will be like this. So here also, this is part of this protocol of hospital-acquired pneumonia. So what will I do at this stage? At this stage, what I will do is, I will look whether this patient has a structural lung disease. Whether the patient has got a structural lung disease. For example, this patient had an emphysema, or this patient has got a fibrosis, or this patient has got a reactive airway disease, or this patient has got cystic lung disease, bronchiectasis, something like that is there. If something like that is there in this patient, or I have a gram stain that shows huge amount of gram-negative bacilli, or I have a gram stain that says it's studded with gram-negative bacilli. Okay, I will still give anti-pseudomonal cover. But here, what is the difference? I'm giving only one. I'm giving only one. Clear? Okay. Clear on this? Plus or minus MRSA will actually depend on the same criteria here. Clear? In fact, no, here I will give two anti-pseudomonal covers. Okay, plus or minus MRSA. But if I don't have any of these, if I don't have any of these features, it will be one anti-pseudomonal cover. That is enough. Clear? So initially it was two anti-pseudomonal covers here, but then I come here and look at this criteria where I have a patient with bronchiectasis or studied with gram-negative bacilli, or there is one more thing. There is one more thing here. There is one more thing here. There has to be more than 50%. If there is more than 50% resistance to the antibiotic that I am starting for Pseudomonas, that is also coming over there. Okay, that means if I know that mera meropenem 50% of the time is resistant and I am starting meropenem, I need two anti-pseudomonal covers. Are you understanding what I am saying?
This will be empirically.
Empirically, yeah, empirically. So you have understood till here. This you have understood. Now I come to a condition where I am not in any of these. There is no structural lung disease. There is no gram-negative bacilli that is studying the gram stain slide. It is not there. However, I know in my ICU, in my hospital, that 50% of the times my Pseudomonas is resistant to that particular beta-lactam. Are you understanding? 50% of the time they are resistant. That means my Pseudomonas that is there in my organism, in my hospital, is resistant. So what will I do? I will actually start two anti-Pseudomonal covers. Clear? Huh? If I have structural lung disease, if I have studied gram stain, I will anyways give two anti-Pseudomonal covers. I understand. If I don't have any of these, then I can give single anti-Pseudomonal cover, and this completes your empirical antibiotics. Simple? So if you break down everything very simply, this is exactly what you mentioned in your this, but it is not broken down properly. So if you break down it like this, it's very simple for you to understand. Clear? Clear on this? Of how to start empirical antibiotics? Once you get the culture, then the story is different. Once you get the culture, you know what to do. I can de-escalate as per what the clinical features are. How long do I give these antibiotics? Not more than 7 to 8 days. I don't need it more than 7 to 8 days. Okay, because giving it for a longer period of time is not going to help me. It's not going to help me. Clear? Is there any way I can predict that there is a CRE? Abhi we didn't even talk about CRE. Is there any way I can predict that there is a CRE? Because CRE by definition, or if there is a CRE, do I need combination therapy? That's a question I have to answer. If I have CRE, do I need combination therapy? So there are scores for that called as increment CPE score. Okay, those scores, you have to put those scores in place and you'll figure out what's happening. Increment CPE score. Okay, that will tell you whether you need combination therapy for a CRE. Okay, as of now we have just discussed up to anti-pseudomonal cover. We have not gone to the CRE issue. Last time I had taught you all CREs, if you remember. DTR किया था मैंने. So there increment CP score we had discussed. Okay, anything you want to ask me now? Is there any questions here now?
So even if in that no structural disease, one anti-pseudomonal treatment with that also MRSA plus or minus.
In this last one, it is not plus or minus. Here you don't start it. It is not required because patient is kind of stable. Patient is in this pathway, so it doesn't require that. Here what they say is, you start anti-pseudomonal cover that has got activity against coagulase negative Staphylococcus aureus, not MRSA.
Sir, if a patient has got VAC, we are thinking that the cause is because of the biofilm and all that, because we intubated the patient. Do we change the tube?
No, nothing like that. The biofilm starts accumulating within 2 hours again.
Okay.
You have to change every 4 hours then. There is no point of taking up a biofilm. It just accumulates within 2 hours. Biofilms are there everywhere. So in fact, I once took a talk on VAP being biofilm VAP. I didn't call it VAP. I called it biofilm pneumonia. I usually call it biofilm pneumonia because it's because of the tube. There's no other
If
reason.
it's a line or anything, we
Again, it's
also
biofilm.
concerned to-
It's again biofilm. It's again biofilm. No, line because you are actually giving something through that. Line is a different situation. You are giving something through that. You're handling it. Here you're not giving anything through that. You're not giving something through that endotracheal tube. Are you understanding? In line, what is happening? You're giving blood. You're giving fluids. You're handling that line very often. No, the approximate number of times you're handling is more than 200 times in a day. The nurse handles the line 200 times in a day. So there you have to change. You understand? There is no alternative. There you have to change. So you can stop this up.